last time we had covered part 1, which was carpal tunnel and the whole ulnar nerve, Ewens canal and cubital tunnel. This is part 2. So we're going to start with median nerve, i.e. pronator syndrome. Then we'll talk a bit about AIN syndrome. And then we'll go on to radial nerve. So pronator syndrome, from exam point of view, important is to know the course of median nerve. So brachial plexus, you should be able to draw it in literally 10 to 20 seconds. And brachial plexus, you can bring it up in many discussions, many vivas. So you should be thorough with it. Median nerve, as you know, it has a contribution from lateral root of median nerve and medial root of median nerve. And then in the arm, it has no nerve supply. In terms of its relationship to brachial artery, at the level of elbow, brachial artery is medial to it, lateral to it, beg your pardon. And in the upper arm, it is medial to it. So remember that relationship. And then carrying on with the course, once it crosses the elbow, it gives nerve supply to these 4 muscles: pronator teres, FCR, palmaris longus, and FDS. Now remember, all these muscles, 4 muscles, are coming from medial epicondyle. The only muscle from medial epicondyle, i.e. FCU, is not supplied by median nerve. So a little sort of a help to remember those. Then once it crosses pronator teres, it gives rise to anterior interosseous nerve, which will then supply FDP to index and middle finger, to flexor pollicis longus, and to pronator quadratus. And then it gives a palmar cutaneous branch 5 centimeters above the wrist, enters into transverse carpal ligament, goes into the wrist, and there median nerve will supply thenar muscles and lumbricals, first and second lumbrical. So a mnemonic here is LOAF, L-O-A-F. L lumbricals, O opponens pollicis, A abductor pollicis brevis, F flexor pollicis brevis. And then of course, median nerve will then give common digital, then proper digital nerves, which will supply radial 3.5 fingers. And palmar cutaneous branch will supply the thenar eminence. So coming to pronator syndrome itself, remember these 2 pictures, that will help you a lot. So pronator syndrome, median nerve, so if you see sometimes 5 or 6 centimeters above the elbow joint, you can have a little, some patients can have a little bony prominence, a spur, from which a ligament can go and attach to medial epicondyle, Struther's ligament. So median nerve can get compressed behind that spur, under the ligament. Then as I was telling you, it goes through 2 heads of pronator teres. So that's a site of compression. Then if you come to this diagram, flexor digitorum superficialis. So its origin is from the medial epicondyle and from the anterior oblique line over radius. So once these 2 heads join, they will have an arch, a sublimous arch. So as median nerve goes through it, it can get compressed. Yeah. So 2 heads of pronator teres there, median nerve can get compressed. Any arches in the body, if a nerve goes through it, it can get compressed. And then bicipital aponeurosis. So if you know these 2 diagrams, it's very easy to understand the sites of compression. Clinical features. So with all these neuropathies in the upper limb, patients will have vague pain. In this case, it will be proximal third volar forearm, because it's quite high up. So they can have sensory disturbance in the radial 3.5 fingers. Then if you know your motor supply of median nerve, which is what we saw in the first screen, patient can have weakness in that motor supply, and then unable to make OK sign, which we're going to see in AIN syndrome, because anterior interosseous nerve supplies FDP to index and middle and to FPL. So they cannot flex their thumb and index finger DIP. They'll keep it extended like that. So they can't do a OK sign, they'll do it this. And then diagnosis. So clinically, because it's going through two heads of pronator teres, if you do a resisted pronation with elbow flexed, nerve will get compressed between the two heads and patient will have pain. So you're increasing the pain and making a diagnosis. It's like doing a Tinel's test or a Phelan's test or a modified Durkin's test in a carpal tunnel. And then of course you can do your EMG or nerve conduction studies. So once you made a diagnosis, management for all the neuropathies is non-operative, wait and watch, unless there's a big lesion like a tumor or a lipoma or a ganglion causing a neuropathy. So you sit on it for good 6 months. Some painkillers, yes, splints, activity modification. So for example, if the nerve is getting compressed in two heads of pronator teres, you would tell patient not to do sort of, if his job involves pronation, a lot of heavy work with forearm in pronation, you will tell patient to refrain from that. And then if in 6 months the pain doesn't settle down, so it should settle down in at least half the cases, 60% cases. If it doesn't, then you want to decompress all the sites, i.e. you want to excise the spur, you want to incise this ligament, you want to incise this muscle so that it's not getting compressed. And then here, that's your FDS arch. You want to incise this whole arch so that nerve becomes free. So let's quickly see pronator syndrome very quickly again. So these two pictures will help you a lot. All the sites of compression. Symptoms are easy, motor and sensory, whatever that nerve supplies. And just remember one provocative test for pronator teres. And then you, once you know this picture, you just need to decompress all of it. Now, remember one more thing. When, let's say it comes to decompression for any nerve in the arm or forearm, you don't go looking for a nerve directly. You always identify the muscle, and that muscle leads you to the nerve. So in this case, you will look for pronator teres, and then in between the two heads, you will find the nerve. If you ever go looking for a nerve directly, you will almost always end up making a mistake. So look for the corresponding muscles. AIN syndrome. So again, this is another sort of a diagram for the nerve. So median nerve, that's your, so as soon as it crosses pronator teres, it gives rise to anterior interosseous nerve, which is going to supply your FPL, FDP to your index and middle and your pronator quadratus. It's a pure motor nerve. And then that's your palmar-cutaneous branch, which is going to supply the thenar eminence on the volar side. And then median nerve itself gives rise to common digital, then proper digitals, which supplies 3.5 radial fingers. So you can so patient can have a pronator syndrome, a AIN syndrome, and for your median nerve in the carpal tunnel, a carpal tunnel syndrome. So 3 syndromes you need to know. And this is another picture which is just sort of reiterating the same point. AIN, motor supply to FTP, to flexor pollicis longus, to pronator quadratus. So AIN palsy. Now, there are lots of associations with AIN palsy. It can be with Personage-Turner syndrome. There can be an accessory FPL muscle, viral illnesses, sternus excise, trauma, iatrogenic, after birth. So let's see Personage-Turner syndrome. In my practice, I'll see maybe 2 cases a year. Again, all we know about Personage-Turner syndrome is, like with AIN palsy, it can happen after viral illnesses, sternus excises, after delivery, iatrogenic, any trauma to that area, any operation to that area. And it basically involves brachial plexus, part of it or all of it, pan-brachial plexus or just part of it. For example, I had one case where C5, C6, suprascapular nerve in isolation was involved. Then AIN palsy is a common association with Personage-Turner. So you can be asked about Personage-Turner or given a case in the exam. Accessory FPL muscle or a Ganser muscle. So we know flexor pollicis longus is going to come from sort of anterior surface of radius, middle 2/3. So that's the flexor pollicis origin. But sometimes you can have this accessory muscle coming from the ulna. It can come from coronoid or it can come from epicondyle like other flexor muscles. So as you can see, anterior interosseous nerve is taking, that's the normal course of the nerve. So this accessory muscle can compress it. So other thing to remember is in upper limb, in hand, you can have all sorts of accessory muscles. You can have accessory muscles like we spoke about in the last lecture causing carpal tunnel. You can have, like I have seen accessory EPL, extensor pollicis longus. So if you are doing an extensor indicis to EPL transfer, and patient had two EPLs, a main EPL and an accessory, you need to know how to do your tendon transfers. So be aware of these accessory muscles, especially if you're doing any approach proximally. You need to be aware of these sort of accessory muscles to deal with it at that time. Yeah. Clinical features, again, AIN, we know it supplies, like we saw in the last slide, AIN supplies flexor pollicis longus, FDP to index and middle, and PQ. So as I was showing you, to make a OK sign, patient has to use a FPL and FDP, which flexes DIPJ. But because both are gone, they will keep their thumb IPJ extended and DIP index finger extended, which is known as a Kilo Neville sign. So that's your one clinical examination. And the other is on attempted flexion, because your FPL is not there and your FDP is not working. So these two fingers will flex, but your thumb, second and third finger will stay out, a benediction sign. So that's your motor examination. Sensory sensations will be normal in median nerve because your AIN is a pure motor nerve. Again, like with most of these neuropathies, AIN palsy is self-limiting. You sit on it for a good year, it tends to resolve. Like Personage, I've seen 3 or 4 cases in the last 2 years, and all you need to do is get them to see a physiotherapist to maintain tone of muscles. Second, EMG study, sort of a baseline around 6 weeks, 2 months, so that you can repeat EMG studies to see if the recovery is happening, so that you can reassure patient and tell patient prognosis. And roughly sort of between 6 months to 1 year, they tend to improve completely. Steroids, I haven't personally used myself, but yes, if there's a lot of inflammation as seen on a scan or otherwise MRI scan, then there's a role for steroids. If it was because of a viral illness, think about antiviral drugs. Only other term to introduce here is Manafelt syndrome. Now, like your Vaughan Jackson, Manafelt happens in rheumatoid. So in scaphoid patients or trapezium, they can have osteophytes and they can cause rupture of FPL tendon or even a FDP2 index finger. So if those tendons are ruptured, which is Manafelt syndrome, patient again will not be able to do a OK sign. So how to distinguish between Manafelt, excuse me, how to distinguish between Manafelt and AIN? In AIN, tendons are intact and tenodesis effect works on a fixed length of tendon. So in our AIN palsy, if I show you on my hand, if I extend my wrist, my thumb and my index finger will automatically flex. But if I flex my wrist, my thumb and index finger will extend. Whereas in a Manafelt syndrome, because tendons are ruptured, whether you flex or extend your wrist, the attitude in thumb and index finger will not change. So that's how you differentiate clinically between the two. Then finally, how you distinguish between your Pronator syndrome from AIN. So same picture again. So Pronator is very high up. That means your radial sensations will be lost in radial 3.5 fingers and in the palmar cutaneous branch, in the thenar eminence. Whereas with AIN syndrome, because it's a pure motor nerve, sensory examination will be normal. And for a carpal tunnel, as you see clinically very commonly, sensations, there's a sensory deficit in radial 3.5 fingers, but the sensations in palmar cutaneous branch is intact. So this is how you differentiate between the three. So I think in terms of median nerve, this is what you're expected to know in the exam: the course, the branches, the motor supply, your pronator syndrome, AIN syndrome, carpal tunnel syndrome, which we discussed the last time. So we will now go on to the tendon transfers. Now, if we know tendon transfers for high median nerve palsy, i.e. let's say at the elbow joint, then high and low is automatically covered. So what's the aim? So the reason I put this picture here is this is the entire motor supply for median nerve. So let's start from the top. Median nerve supplies these 4 muscles. Now, because pronator teres and pronator quadrators both are gone in a high median nerve, we need to restore pronation for patient. Pronation is very important for all those people who work on computers or writing jobs, because you pronate your forearm and that's how you type and write. So pronator teres will have to do a tendon transfer for that, so that we can use biceps to help us. FCR not needed because you still have an intact flexor carpi ulnaris, which is supplied by the ulnar nerve. For maris longus, we know it's not needed. FDS again not needed because you have flexor digitorum profundus. Flexor digitorum profundus to middle and index is gone, but we can do tendon transfer for flexor digitorum profundus. So FDS, we don't need to do tendon transfers. Then flexor pollicis longus, it is used to flex the IPJ of thumb, which is very important because thumb is 40% of your hand function. So we need to do tendon transfer for flexor pollicis longus. Then let's talk about PQ. We don't need it because we are doing a tendon transfer for pronator teres. Then as it comes in the wrist and supplies the thumb, abduct APB, flexor pollicis brevis, or opponens pollicis. Together, these 3 muscles do opposition of the thumb. So we need to restore thumb opposition, and we'll use a tendon transfer to abductor pollicis brevis. We ignore the other 2 muscles, i.e. the flexor and the opponens, and we'll see in the coming slides why we do that. And then in first and second lumbrical, well, lumbricals and interossei, they flex MCPs and extend interphalangeal joints. So because we've got intact palmar and dorsal interossei, we don't need to do any tendon transfers for lumbricals. So for your tendon transfers, I personally think this diagram helps. So going through this, so we're going to restore pronation. We need to restore DIP flexion to index and middle, thumb IPJ flexion, and thumb opposition. So let's see them in a bit of detail. So thumb opposition. So if median nerve is compressed either in carpal tunnel, which is a common scenario, you can be given a case and asked to describe tendon transfers for thumb opposition, or whether there's a high median nerve palsy because of pronator syndrome or a stab injury or after a fracture. But if the loaf muscles, the thumb muscles are gone, then you need to know thumb opposition tendon transfers. Now, before we come to that, the reason I put these 2 pictures here, you can be asked to describe thumb movements. Now, we all know about, or let me show you actually, it's easier that way. So if this is the hand, that's flexion, extension in plane of the palm, abduction perpendicular to palm, that's adduction. And finally, opposition is when I bring my thumb to touch the other fingers. Now, thumb opposition starts with abduction. So the opposition initiator is abduction. No, I think you can see it better this way. Okay, so abduction, and then if you flex MCPJ, and then you are able to touch your other finger. Yeah. And then pronation, when I'm doing this, so initiation is abduction, flexion happens at MCPJ, and in all this, pronation is happening at the CMCJ. So if you're asked to describe opposition in the exam, this is how you're going to describe it. So if you see MCPJ, it's like elbow, there's only flexion and sort of flexion extension. That's the only movement which can happen here. Whereas at the CMCJ, all the movements happen: flexion, extension, abduction, and pronation. So this is how you get your thumb opposition. So since we said the initiator was abduction, unless thumb abducts, it can't oppose. So that is why when you do your tendon transfers to restore thumb opposition, it is to the abductor pollicis brevis. So now, what options do you have? So you can literally use any tendon at your as you wish. You can take flexor digitorum superficialis to ring finger, palmaris longus, abductor digiti minimi, or extensor indicis proprius. They have various names. Important is Thompson transfer, where you take FDS in a young person. Chemist transfer, where you use palmaris longus in an elderly person, because palmaris longus is not that strong. Two more things to know here. Why create pulleys? So pulley changes the vector of pull of your tendon, which makes tendon more efficient, much more efficient. That's why in our whole bodies, we have lots of pulleys. For example, we've got a pisiform in FCU, we've got sesamoids in thumb. So we've got pulleys everywhere to help us. Similarly, some of you may have seen in hospitals, sort of 30 years back, I'm not sure if it still happens in some sort of remote parts in India still, for like femur fractures or tibia fractures, when patient was given a plaster, you would see pulleys suspended from the top of the bed ends. So that makes the whole system, traction, counter traction, very efficient. So pulleys are our very good friends, and we try and create pulleys when we do tendon transfers. The other thing is principles of tendon transfers. There's another question for exam. So if you were to transfer something, if I was to do a Thompson transfer, transferring a FDS to abductor pollicis brevis, so my MCP of thumb has to be supple. It should be a congruous stable joint. There should be no infection. Tendons have to have a straight line of pull, which I'm going to show you in some of my operative slides, what that means. And then it should be at least a grade 4 motor power, because you're going to lose one grade, and you need at least grade 3 to have movements against gravity. So let's start with Thompson transfer. So basically, again, FDS to ring finger. That's a very good friend of yours for all your tendon transfer work. You can use it for your thumb opposition, for your FPL ruptures in distal radius fractures when you plate it. You can use it for Vaughan Jacksons, for your Manafelds, pretty much anything. So FPL to ring finger, you can pretty much bring it up in any tendon transfer discussion in your exams. So again, in the following slides, I'll show you where exactly the incision is, but incision is from A1 pulley right up to 6-7 centimeters proximal to the wrist crease. So a big incision. You need to first confirm that it's an FDS, not a FDP. So you identify your FDS here, and then your FDS proximal to your wrist crease, and then you pull on it. And if there's a flexion at the PIPJ, then you know it's FDS. And your DIP is floppy, that means it's FDS. Then you divide it here, you pull it out. This is your FDS. So this FDS was there, divided. And then you create a pulley. So pulley is, from the same incision, you can approach your flexor carpi ulnaris. Just take half of FCU, 3 or 4 centimeters, make a pulley, and then pass the FDS through that and attach it to abductor pollicis brevis. Now, pulley, we know why we've created. It changes the vector of pull. You can see here, it is at right angles now, makes your tendon pull more efficient. Why abductor pollicis brevis? Because then it can abduct the thumb. And again, if I may show you, once my FDS abducts the thumb, now I can cleverly use, my patient can cleverly use his FPL, which is supplied by anterior interosseous nerve, and then bring that finger to the thumb. This is how they do opposition for a low median nerve palsy. Then Camet's transfer, which is what I do fairly commonly, because in my hospital patient demographics is such that I get a lot of elderly people with carpal tunnels. So in this, what you do is you use your palmaris longus. The key here is you need to make, or if I show you this picture, because you need to bring your palmaris longus to MCPJ of the thumb. That's where abductor pollicis brevis is. So you need to make a little slip out of the palmar fascia. Otherwise, you will struggle with the length. So go right up to A1 pulley, make a sleeve, make it into a tendon. You can put some sutures to make it into a, to sort of fold the sleeve onto itself. Then make a subcutaneous tunnel, and then you attach your palmaris longus to abductor pollicis brevis. Few things here. Remember, to do carpal tunnel, we go through the fascia. So if you're planning to do your chemist transfer, first you just need to incise your skin, retract your skin and fat, and make a sleeve out of your fascia before you cut the transverse carpal ligament. Second thing to appreciate, length of your harvested tendon is always a limiting factor. So try and harvest as much length as you can for any tendon transfer work. Third thing, when you do a tendon transfer, you have to build in maximum tension, because post-operatively there'll be some myostatic relaxation. So it's always good to build in some tension. In fact, you cannot build in excessive tension, so build as much as you can. Burke halter, personally, I've never done this, but they're using extensor indices. So again, from the dorsum, we know the ulnar, so index finger has got two tendons, EDC and EIP. The ulnar tendon should be EIP. So a small incision to MCPJ, then distal to extensor retinaculum. Once you've confirmed this is your extensor indices, you cut at the MCP, deliver it here, then come out through the ulnar wound. That's your EIP. And then EIP should come right up to APB, which is again your MCPJ, and attach there. Abductor pollicis brevis. So whichever tendon you are using, FDS, palmaris longus, extensor indices, anything, it needs to attach to abductor pollicis brevis so that it can initiate abduction to the thumb. Then let's see, so we were talking about flexor digitorum profundus to index and to the middle finger. Sorry, beg your pardon. Let's do the thumb IPJ flexion first. So we've done thumb opposition, then thumb IPJ flexion, so flexor pollicis longus. Again, as I was telling you, FDS is your best friend. So I'm going to show you some operative slides of a patient of mine. But this is from a patient who had a distal radius fracture, and then FPL got ruptured year and a half back and referred to me from a different hospital. But principles are the same. So so what I've shown here is, so see, incision is quite big, right up to A1 pulley. That's where you harvest your FDS. And then incision right up to there, because the whole distal radius plate was taken out. Now, so in this first slide, I've just shown you the incision, and you can see just about see the screws in the plate, and that's the ruptured end. That's the FPL ruptured end there, and that's the other end. Yeah. And then this slide shows the harvested FDS. So as I was telling you, once I've identified that this is the FDS 2-ring finger and not the FDP, see how much length I've got. So you cut just before the optic chiasma, hoping patient won't get swan neck finger. And once I've done that, and that's the FDS going there, what you can see is there is a bend here. It's not straight. Excuse me, sorry. And we want tendons to have a straight line of pull. So if you now compare this slide with my artery forceps, that's the tendon. And you can see it's a straight line of pull. There's no bend here. So what you have to do is throughout the length of FDS, you have to release all the adhesions so that muscle and tendon are in a straight line. So that is what you mean by straight line of pull. And then once you've done that, then I've done a pulvotaft weave. So we saw the ruptured end of FPL there, and I've done 3 or 4 weaves, and you can see this looks quite bulky. So that's a pulvotaft weave, and that's my FDS tendon now. So see the straight line of pull basically. And other thing was we were talking about, okay, if I may bring your sort of attention to the point here about the tension. So here I'm not touching the thumb, but if you see after the weave, thumb is fully flexed at IPJ and even flexed at MCPJ. So I built in a lot of tension in my FPL tendon transfer, because post surgery there'll be some myostatic relaxation of the muscle there, and this will automatically extend. And if the tendon is not under some tension, it will not flex the IPJ to the thumb. So now you can see, despite me putting my thumb pressure onto MCP, still IPJ is not extending, it's still flexed. So I'm pushing thumb down, tenodesis effect, this should have extended. In a normal person, the moment you do this, thumb will extend. So which shows that good tension is there, which is very important for thumb function. Then we need to restore the FDP to index and middle, which is very easy. It literally takes 2 or 3 minutes. So with the same incision, like I was showing you for the FDS, once you take FDS to one side, the deep flexor to the forearm is FDP. And you can see all the 4 tendons, flexor digitorum profundus tendons. And we know the second and third is gone because of median of palsy. So all you need to do is attach these two to ring and little finger, just like a en masse stitch. There's no science to it, just like a big en masse stitch. Restore pronation. Now I have never done this myself, but you need to use a biceps tendon. So that's why I've not put any slides. It's just more academic for you to bring it up in the exam. It's just biceps because it's attached to the radial tuberosity. You need to reroute in a way that it starts pronating, basically. So that was median nerve in total. So we spoke about pronator syndrome, AIN syndrome, median nerve course is branches, tendon transfers to restore thumb opposition, thumb flexion, your DIP flexion to your second and third finger, and then forearm pronation with biceps rerouting. Then let's come to supinator. So let's come to radial nerve. In radial nerve, we're going to talk about supinator tunnel syndrome, very briefly about radial tunnel syndrome, then your Wartenberg syndrome, and your Saturday night palsy. These are the 3 or 4 neuropathies which can be asked in the exams. So in terms of radial nerve, I hope these 3 pictures will help. So if we start, let's say we start from there. So again, radial nerve course, we know it comes from posterior cord of brachial plexus. That's why it has all the nerve roots, contributions from C5 to T1, and then it's going to become posterior, runs in the spiral groove with profunda brachii. So it's running there, and in the groove, it gives branches to medial head, lateral head, And this long fellow there, that's the branch to anconeus muscle. And yes, in the axilla is going to supply the long head. And then it again comes in the front where it gives branches to brachioradialis and ECRL, then divides into two, superficial radial nerve, posterior interosseous nerve. Posterior interosseous nerve will pierce the arcade of Froche in supinator muscle, and it goes posterior. In the posterior compartment of forearm is going to supply all the extensor muscles, and then superficial radial nerve itself will supply dorsoradial hand, like half of the hand, if you like. Now, if we see the branches again, so in the axilla, it supplies long head of triceps. In the arm, in the posterior arm, in the spiral groove, it supplies triceps, medial lateral head, and anconeus. In the front, in the volar forearm, brachialis, well, brachialis is only proprioceptive, remember that. Motor supply is musculocutaneous. But its motor supply is to brachioradialis and ECRL. Some articular branches to elbow joint, proprioceptive branches to elbow joint. And then the deep branch or the pin, posterior interosseous nerve, is going to be at the back. And an easy way to remember about a motor supply of posterior interosseous nerve is, obviously it's going to supply supinator because it's going through the two heads. And then how I remember is, if you see your hand, so if you start from the ulnar side, it supplies ECU, EDM, EDCs, EI, thumb will be APL, EPB, EPL. So that way, like if you have one order, you can name the muscles very sort of easily and quickly. So supinator tunnel syndrome. So as we were saying, radial nerve, the motor branch goes through the two heads of supinator, like your median nerve through two heads of pronator teres. So every time it goes, any nerve which goes in between two muscles is bound to have some potential entrapment. So this arch, like your sublimus arch in FDS, is known as arcade of Froche. And when the nerve goes through it, this is a site of compression. Then as it is coming out, that's a site of compression. Then in front of radiocapitellar joint, you can have synovitis in the joint in rheumatoid patients. You have lipomas, ganglions, nerve tumors, remember all those, and then recurrent leach of Henry vessels and ECRB needle edge. So if you think of these pictures, you can easily remember the causes. And in any nerve entrapment, always think of ganglions, lipomas, and nerve tumors. Clinical features, again, like pronator syndrome, patient may have deep ache because it's a pure motor nerve, so there'll be no problems with sensations. There can be a motor weakness, and this is the only feature which tends to distinguish it from radial tunnel. So remember, in pin entrapment, there can be a motor weakness. And tenderness obviously is going to be 3, 4, 5 centimeters distal to the epicondyle. Epicondyle is tennis elbow, and if it's 5 centimeter distal, it's going to be pin entrapment. Provocative test. So it's going through supinator. If you ask patient to do a resisted supination with elbow extended so that biceps is not acting, patient will have pain. Similarly, because it's supplying all the extensors, any resisted extension to the long finger or any finger for that matter will give pain in the volar proximal or forearm, basically. Along with that, in terms of investigations, you can get an ultrasound, because ultrasound will tell you the caliber of the nerve, the quality of the nerve. You can get an MRI scan. It can pick up lipomas and ganglions and nerve tumors. You can get your nerve conduction studies, and this is how you'll make a diagnosis. In terms of approach, again, this is one of my sort of patient. So some slides, operative slides. Now, few things to remember here. One, normally the feeling is, if you want to see supinator, you should do a Henry's approach, i.e. go between your brachioradialis and your FCR, or brachioradialis and pronator teres proximally. But to see the whole length of supinator, You can't go between brachioradialis and pronator teres. You have to do a much more posterior approach. So in this picture, they have gone between ECRB and EDC, but practically sort of, so you can do any approach, but not a Henry's approach. You can go between ECRL, ECRB, ECRB, EDC, and so on. So that's important to appreciate. Now, I was just thinking last night when I was going through the slides, if I remember, I had gone between ECRL and ECRB, and I'll give you my reasons why. If you see, so this is shoulder, this is elbow, that's shoulder end, and that's the hand end. So that's the radial nerve, and you can see it's dividing into two branches. That's the superficial radial nerve, and this is your posterior introitious nerve. So this becomes your radiocapitellar joint. Now, if you see superficial radial nerve, it's sort of going deeper. So I feel it'll now follow the sort of or run under the lower border of medial border of brachioradialis. So I think this was ECRL and this is then ECRB. And then if you see posterior introitious nerve, you can see it's giving a branch here. That's the branch to supinator muscle. And that's your supinator muscle. You can see the muscle, sort of the color of the muscle there. Excuse me. And this is the arcade. That's the arcade of Froche. So posterior introitious nerve is going there into the arcade of Froche. Now, other thing to notice here is the quality of the nerve. If you see, nerve is nice and shiny, which is how it should be. A normal nerve looks like this. But compare your superficial radial nerve to your pin. Pin looks a bit big, looks very dull. And look at this fellow here, two big veins. And if I show you the next slide, before I tell you the history, or if I go to the next slide further, you can see four very engorged veins. And these were the reasons, this was the reason why this patient had a pin entrapment, if you like, a pressure on the nerve. So this guy was Afro-Caribbean, I remember him well. He had both the symptoms for supinator tunnel and tennis elbow. Remember, tennis elbow has a 5 to 10%, 5% association with supinator tunnel. So you need to look for tennis elbows in any case where you're suspecting a pin entrapment. Then even though MRI was normal, ultrasound did suggest an acute caliber change in pin. So you can see pin, there's a caliber change and there's a quality is different also, it's very dull. And then, so you can see this, so when I dissected it further, you saw these big four veins. And the other thing to notice here, so all these four veins were ligated to take the pressure off pin. And you can see pin dipping into arcade of Froche. But if you compare this slide, see that's the arcade and look at the muscle color, that arcade is gone. So this is where the arcade was. And the whole length of supinator was basically decompressed. It took him a good 9 months still to recover after, to fully completely recover. So what I'm trying to say here is pin entrapment does occur. It's very rare. You'll see one case in 3 years, at least in my practice, 1 in 2 years, 3 years. And it can be even veins. It just doesn't have to be recurrent lesion of Henry vessels. It can easily be a vein also. So your clinical examination, your clinical suspicion, ultrasounds, MRIs, you have to put all of them into perspective to make a diagnosis. Radial tunnel syndrome. Now, I have personally not seen one. Maybe I've missed, maybe I'm not that clever to pick those up. But for exam purpose, essentially radial tunnel, everything is normal. Sensations are fine, motor examination is fine, EMG is fine. So how do you make a diagnosis? Like, how will you know then if everything is fine? So one, the site of pain will be proximal to sort of supinator tunnel. Second is, if you give a local, pain should settle down. In a tennis elbow, it won't, but in a radial tunnel, it will. So as I said, I have never seen one or decompress one, but if they bring it up in the exam, at least you have 1 or 2 sensible things to say about it. So let's see the tendon transfers for radial nerve. So the whole idea is, so let's say someone had a stab injury in mid-humerus and the radial nerve was completely transected, or even iatrogenic, or a bad nerve tumor. But either ways, that nerve didn't recover, let's say despite repair, or it was a missed injury. So then so the aim will be, you want to have your you want to give your patient back his wrist extension, fingers extension, and your thumb extension. These are the three things you want to restore. Now we'll look at these two pictures in 2 minutes, but we'll go to the other slides first. So for wrist extension, so let me show you the other slide, but yes, wrist extension, you use your pronator teres to ECRB. Fingers, you can use your FCR, FCU to EDC. Thumb extension, you can use your palmaris longus. As I told you, FDS to ring finger is your best friend. You can use your FDS and take it to EPL. So let's talk about wrist extension first. Pronator teres. So we know it has two heads, epicondyle, ulna, proximal ulna, and that's where median nerve gets compressed, and it's inserted exactly sort of upper third on the lateral border. Yeah. And then your extensor carpi radialis brevis is supposed to, this is the volar forearm, that's your dorsum. So ECRB again comes from epicondyle, and it comes and sits in the middle metacarpal at the base. Yeah. ECRL on the other hand comes and sits on the second metacarpal. So both are extensors along with ECU, of course, but because this muscle, this tendon sits on the middle metacarpal, it will give a symmetric wrist extension. So if I take my pronator teres off from here and with a bit of periosteal sleeve, because as I said, tendon length is always an issue. So you take a bit of periosteum with it. And then from volar, if you imagine this tendon is right there, I can bring a PT from the front and just attach it here. And then it'll become a wrist extensor. So that's my first tendon transfer. Then for my fingers, my EDCs are my finger extensors. They extend my MCPs, my PIPs and DIPs to all the 4 fingers. So if I bring your attention to this picture there, if you see flexor carpi radialis, again, it comes from your medial epicondyle and then comes and sits on volar base second and third metacarpal. So if I take this flexor carpi radialis and cut it off at the wrist crease, and then if I bring your attention to this picture, so I've cut it off at the wrist crease, then I can take my FCR radially, thumb radially, and then if you see this one, this is from the back of the forearm and hand. So that's my flexor carpi radialis with my tendon. And just proximal to the extensor retinaculum, I can incise my 4 EDCs, and then FCR, I can attach it to the EDCs. So then flexor carpi radialis will give me my finger extension. Then, of course, you could have used your flexor carpi ulnaris if you wanted to, but the only thing is FCU is, so the position of function in a hand is ulnar deviation. So your FCU gives flexion and ulnar deviation. So you want to preserve your FCU. If it comes to sacrificing one, it's better to sacrifice FCR. And I would use my FCR like whole thickness, not just half of it, for my trapeziectomy and ligament reconstruction tendon interposition. And I've not noticed a patient come back with any problems to flexion. So FCR is a very expandable tendon. Then for EPL, extensor pollicis longus, I can easily take my palmaris longus. So palmaris longus again comes from medial epicondyle, and it's not going to insert anywhere. It's into a palmar fascia. So again, if I just cut it off incise it at the wrist crease, and then if I bring your attention to this picture, that's your EPL tendon to the thumb. That's the musculotendinous junction. If I just incise my EPL tendon at the musculotendinous junction, so I get the maximum length of tendon, then I take it out of extensor retinaculum, and then it needs to come on the sort of a volar surface, flexor surface, and that's where my palmaris longus is, and I can attach the two. So palmaris longus, if you think will cause both extension but abduction, because the tendon now is in a very different direction to what nature gave us. So obviously it will not only cause extension but a bit of abduction. So if I take you back to those pictures which we were talking about, so if you see now, this is volar forearm, that's palmaris longus, FCR, that's pronator teres, and that's the periostal sleeve, because otherwise pronator teres is not, we don't have enough length. So all of them have come through this one long incision. And then if you come to this diagram, pronator teres goes and attaches to ECRB. FCR, they're all coming from the thumb side, goes and attaches to the EDC. Palmaris longus will attach to EPL. EPL can be here or a bit volar, doesn't matter. This is how you achieve your wrist extension, finger extension, and thumb extension. And you can see clearly here that this tendon is at 1/3, exact 1/3, whereas ECRP becomes tendinous in roughly half of the radius. So you need a bit of periostal sleeve to attach here. Then final few slides. So we've talked about supinator syndrome. We've talked about very briefly about radial tunnel. Saturday night palsy is just sort of, the reason it's called Saturday night because after heavy drinking, classically patient would sleep in a chair and a hard surface is in the axilla. So we know the radial nerve is coming from this area going into the posterior forearm. So it will result in demyelination and radial nerve neuropraxia. And patient will then get up and wake up next morning with a wrist drop. And it will also affect elbow extension. In terms of obviously in terms of differentials, you need to rule out fractures, or yes, stab wounds, puncture wounds, crush injuries, blunt traumas, or shoulder dislocations. So there will be a history. History will straight away guide you towards differentials. In terms of management, like with Personage-Turner syndrome, examination, then EMG study after 4 to 6 weeks, serial EMG studies for 1 year, so at least 2 or 3 studies to show the recovery, to tell patient about prognosis, and to reassure the patient. So serial EMG study is very important. Liaise with your hand therapist, a wrist drop splint, and hand therapy to keep the tone of muscles. Then Wartenberg syndrome to complete the radial nerve in its entirety. Robert Wartenberg, I think 1930s, 1932, he was the guy who described that, called it as chiralgia paresthetica, as opposed to meralgia paresthetica, which is your lateral cutaneous nerve or femoral nerve, I think, if I remember. Again, causes can be anything, can be tumors, can be trauma, can be iatrogeny, can be lipomas, can be ganglions, vessels, accessory muscles. As I told you, they're if you look for them, you'll find them everywhere in the upper limb. And of course, classically watch can put pressure. Symptoms will be, if I take you to the next slide, so that's your superficial radial nerve. From the volar side, it comes between brachioradialis and ECRL, divides into a couple of branches. There can be 2 to 4 branches, which supplies dorsal-radial head. So if someone has a Wartenberg syndrome, Tinel's here will be positive. There will be paresthesia, pins, needles, and numbness in the dorsal radial hand. And this is another diagram to show the same. Brachioradialis, ECRL, that's the Wartenberg's point, site of compression. And again, there's a scissoring action between brachioradialis and ECRL. So on pronation, resisted pronation, scissoring action, nerve gets caught, patient gets pain or paresthesia. Again, management, like with anything, activity modification. So any jobs which involve a lot of pronation, you sort of need to do some activity modifications for that. Then any tight wristwatches or bands, wristbands, try and not use those. A lot of inflammation on ultrasounds. You can have ultrasound guided steroid injection. Sit on it for 4 to 6 months. If it doesn't work, then you have to surgically decompress it. And I think this is the very last point. Wartenberg syndrome is superficial radial nerve as opposed to a Wartenberg sign, which is your ulnar nerve. So you should know about your Wartenberg sign as well and the difference. And I think, yeah, that's the sort of end of it. Thank you very much for your attention.
Thank you, Saurabh, for that brilliant presentation as usual. Just a few questions.
Yeah, sure. Thank you.
Can the radial nerve also be entrapped in the lower triangular space near the axilla?
I wouldn't know because even if it's axilla, I won't see it. I've never seen one. But when you say lower triangular space, what are the boundaries? What are we talking about here?
No, see, when we have the quadrangular space, upper triangular space, and lower triangular space, right? So the radial nerve probably exits at the lower triangular space, isn't it?
So you're right.
From my old anatomy lessons.
No. Let me imagine in my mind. Quadrangular space is your neck of humerus, your teres minus, teres major, and long head of triceps, if I remember. Radial nerve comes out with profunda brachii.
Exactly. Is it possible, right? Is there an entity?
I haven't. Anything is possible, you're right. But personally, because we've not heard of nerve getting entrapped in quadrangular space, that means there's space big enough for it not to entrap it. So if I extrapolate it to triangular space, I haven't come across anything in the literature. Have you, Hitesh?
No, I've just randomly, I've heard about the quadrangular space syndrome and the lower triangular space syndrome. That's what I asked. That's the reason I asked you.
If you heard about, I'm sure it gets entrapped. I haven't come across it.
Okay, not an issue. The other one is, Saurabh, have you heard of an entity called the crutch palsy? Those who, something similar to the Saturday night palsy, those
yes,
crutches?
Absolutely. Crutch palsy, honeymoon palsy, Saturday night palsy. Anything which puts pressure on the upper medial arm will result in radial nerve demyelination and neuropraxia. It's exactly the same thing.
Thank you, Saurabh, for that. Saurabh, can you mention about the post-op management on whenever you do these tendon transfers? How do you go about the post-operative management in general? We talked about the Jones transfer and as well as the forearm, volar transfers. So what are the general principles that you follow in the post-operative period?
Right, okay. So few things. One, tendon harvesting is very important. You need to get maximum length. You need to make an effort to do that. Second, straight line of pull. You need to release all the adhesions right up to musculotendinous junction. Otherwise, that tendon will not be effective. Third, pulvotaft weave if possible. So your weave is important. Fourth, maximum tension. That's very important. I've seen people hesitate to give too much tension. I give as much tension as I can achieve, and I've never regretted. In terms of now post-operative, I tend to, so there are two ways with it. I tend to protect them for a month in a plaster with maximum tension. And then after a month, they need to go on a splint where you are allowed active contraction of a muscle, but not passive. And you don't stretch the muscle. Splint goes in a way that it only allows, for example, in a thumb, splint will go in a way that it will allow flexion to my thumb, FPL, but not extension. So splint will be in this position. So you're not passively stretching your tendon transfer for two and a half months.
Okay, thank you, Saurabh. And just before we conclude, one thing about the radial tunnel syndrome. See, we've been, whenever we talk about tennis elbow, one of the differential diagnoses in a tennis elbow is a radial tunnel syndrome, isn't it? So clinically, can we say that the tenderness in a radial tunnel syndrome is going to be slightly more distal?
Correct.
1 to 2 finger breadth distal to the lateral epicondyle, isn't it right?
Absolutely. So for tennis elbow, the clinical examination is very classical. If you draw an imaginary line below the lateral epicondyle, Anything in front is tennis elbow, ECRB. Anything behind is your LUCL. So what I do is you come below epicondyle and a centimeter in front and you palpate. Patient will jump in pain. Along with, you can do resisted extension to middle finger. Whereas in radial tunnel, they say the length of tunnel is 3 to 5 centimeters. So right from your epicondyle, right up to the arcade of Froche. So if there's pain in those areas and you've ruled out your tennis elbow, you can get an MRI or ultrasound, you will have an idea. Same MRI can rule out your supinator. Then you can label it as radial tunnel. You can get an ultrasound guided local there, and if pain goes away, that's confirmatory. Personally, I have seen a few supinator tunnels, maybe 3 or 4 in last 4 years, so 1 a year. Never a radial tunnel. Maybe I underdiagnose, or I'm not that clever. I'm not sure.
So when you mention about supinator tunnel, is it the posterior introducer nerve itself, isn't it?
Yes. Yes.
So why did you say that this is a supinator tunnel rather than a radial tunnel syndrome?
So with supinator, like I showed you in that example.
Yeah, that's fine. You can just mention about it.
Yeah, okay. So here, for example, when we got an ultrasound said there was a caliber change in pin at the level of arcade of Froche. And when I actually went in, if you see like your carpal tunnels, the nerve right in front is all very dull. So ultrasound normally sort of immediately, like is your friend. If you have a nice MSK radiologist and they say, well, there's something wrong just before arcade, because arcade, so there were 3 or 4 veins here which were putting pressure. So nerve got dull and hypertrophied. So this, it's an educated guess. You will never know 100% that it is a supinator tunnel.
Okay, and also the leash of Henry, right? So I remember that there are a few causes for the radial tunnel syndrome, and I remember it as FREAS, freeze. The fibrous bands, recurrent leash of Henry, isn't it?
Correct. So
edge of supinator.
I know, exactly. These are the same causes for your supinator tunnel also. Radial tunnel, because it's 3 to 5 centimeters proximal, so radiocapitellar synovitis, any lipomas there, ganglions there, any bands there, and the same will amount to supinator also almost. So I think the one distinguishing feature is your motor weakness also. In PIN, a patient can have motor weakness, but it's hard to distinguish, and a very rare entity basically.
Okay, Saurabh. I think that's all the questions that we have for this session, Saurabh. Thank you for joining. It was, as usual, people were asking for a lecture since long. They've been messaging me on various platforms. Please, I'll request Saurabh to present the part 2 of his lecture. And there you are.
It is always a pleasure to come on Orthopedic Principles, Hitesh. I've just we've been in touch, we've been talking. I just got a bit busy because of COVID in London and other stuff. But I'm looking forward to another lecture in November, which I can discuss with you after sort of the session.
Thank you, Saurabh.
Pleasure, Hitesh. Thank you for your kind invitation.
Bye-bye.